Okay, so I'm going to speak about genetic heterogeneity in GM1. And just note that this was data that was collected, analyzed, and presented in a poster at the World Symposium earlier this year. And it was put together and assessed by Vanessa Rangel-Miller and Christine Wagner and myself on behalf of GM1 Foundation. And the data had been collected by Allstripes, which was then bought by Picnic Health, and so we had some collaboration from there as well. So as background, we all know about GM1 gangliosidosis. It's a progressive, ultra-rare neurodegenerative disorder. It's inherited autosomal recessive, and because of the deficiency in the ß-galactosidase enzyme, it leads to functional impairment. And we know that it's really the buildup of these GM1 gangliosides and that leads to the multi-organ dysfunction, the ultimate developmental delays, and also regression. So I think one of the important things that we need to know going forward is how can we predict how patients will do and when is the right time to intervene, assuming that we're going to have good interventions. So we need to really understand the natural history of the disease and also the genotypic diversity of GM1 and how that may correlate to the clinical or the phenotype that is seen in patients. So as we know, GM1 is not currently included in newborn screening, and we hope someday that it will be, especially if there are early interventions that can be used. So at this point, we have significant unmet needs in this community. This is a cartoon just looking at the pathophysiology of GM1 disease, and not only does the gangliosides increase in the lysosomes, but it can have a detrimental effect on many aspects or many other organelles within the cell, including the very important mitochondria. So in this study, it was a natural history study or a registry, and patients participated that lived in the US, the UK, or Canada, and they needed to have a confirmed diagnosis, and then they agreed to have their medical records digitized, and then Allstripe trained clinical abstractors went through the medical records to abstract clinical data on the patients. And as such, they looked for some specific developmental milestones that were achieved and as well as lost. And I think one of the downsides is we don't really have, excuse me, standardized, GM1 assessments. So we were really leaving it up to the abstractors to try to collect what they felt were most appropriate for certain developmental milestones. And unfortunately, they were inconsistently reported. We may have, for example, captured when a child stopped walking, but not necessarily when they started walking. So we didn't always have the good correlations. This data was provided to us in a de-identified manner. And we looked at the clinical assessments as well as the GM1 subtypes that were assigned. And what we did was we went back and ensured that those were correct and reassigned some of them, and then as well looked at the genotypic variant classifications. So let me go through some of these results. So there were 26 participants in the study. And based on our assessments of the clinical data, there were 5 patients that were categorized as type 1, early infantile, and then type 2A, late infantile. There were 6. There were 12 in the type 2B, juvenile. And then there were 3 where we just didn't have enough data to determine, but they were type 2 unspecified. Type 3 or adult patients were not part of the sample size. The majority were male, 62%. The majority lived in the US, 81%. The mean age of symptom onset was 26.4 months, and the mean age of diagnosis was 67.3 months, which of course there was significant variability based on the subtypes. As you might imagine, The majority of symptoms were motor, sensory, and cognitive. We also saw quite a number of bony abnormalities that is very typically seen in these patients that were also reported. And as you can see, all 26 patients are captured here and categorized by subtype, and we then ascribed these different GM1 clinical symptoms that were diagnosed, that were early presenting symptoms and or signs. This looks at the age and months of symptom onset, which are the green dots, and diagnosis, the purple dots, so each line represents a unique patient. And as you can see, there's a lot of variability. The time between the two was between 3 months and 263 months. And of course, we might expect that it was the juvenile patients that had that longest delay from symptoms, which some of it was really in retrospect because some of the symptoms were more subtle. So these were the signs and symptoms at onset, and primarily these were in the areas of developmental regression and also cognitive decline. As well, we saw hypotonia and seizures that were rather prominent, and some of our juvenile patients in particular, as they progressed, though they had learned to walk, started having unsteady gait and falls. And also, as mentioned, we see quite a number of bony abnormalities, kyphosis, in particular, scoliosis as well, and then the various symptoms I think we're used to seeing: sleep disturbances, organomegaly, dysarthria, dysphagia, swallowing difficulties, hearing impairment, ophthalmology changes, etc. We also looked at the genotypes, and these are all presented here for all of the participants. And there were, majority of these were previously known, but there were 4 genotypes that were recurring, and and others were unique to the patients. Overall, when looking at the variant classification, 86% of the variants were identified as known to be pathogenic or likely pathogenic. These are a couple of cases that we saw in patients. So this is a patient that was diagnosed with type 2A late infantile. And as you can see, the child had had normal development that was recorded to at least 11 months of age, where they were meeting developmental milestones on target. However, between 11 and 16 months, there appeared to be some regression or delay in acquiring new and expressive or receptive language. And looking at one of the patients that had a juvenile onset, this patient, thank you, was seen to have pretty normal development, definitely in the first 2 years, and then starting at age 3 had some delays in gross and fine motor, although was still also acquiring some new skills up to age 5. But then between 6 years and diagnosis at 11, definitely was having loss of previously acquired developmental skills. So overall, GM1 patients face significant delays in diagnosis due to the variability of symptoms and also the subtle changes in development that may not be appreciated early and are associated with the later onset juvenile forms. We saw significant genetic heterogeneity, and we know that there are approximately 265 variants that have been diagnosed or that have been reported, and we are able to contribute to the genetic knowledge of GM1. In the future, it will be really important to correlate the genotype with the phenotype. Unfortunately, that was not data that we were able to obtain in this study population, though we really tried to get that information. We also don't know what the epigenetic or other genetic factors may be that will impact that genotype-phenotype correlation. But this will be important going forward to really, I think, understand the possibility of earlier diagnosis and screening, in particular newborn screening. And overall, it really supports the need for a comprehensive database and registry to obtain more information globally, share this information, and hopefully provide further correlation between genotype, phenotype, and subtype classifications so we can more fully understand natural history of disease. Thank you.